Or no, I think presenter. I think
Oh, there we go.
oh, there's Rosie. Gavin, is there any, can you release mine as well?
No, that didn't start the webinar, didn't it?
No, I don't think so, no.
I don't see an option. Do you see an option now, Rosie, to start webinar?
Oh, we just lost Rosie's. Oh, there you go.
Sorry. No, I think I already clicked start webinar. Sorry.
So good. Well, we have a few minutes before we get started.
Yeah. So good evening,
Everyone's
everyone
gonna
that has joined the webinar already. We've gotten started it a little early, so we're just going to allow a couple more minutes for some attendees to join. So we'll jump back on in a minute. Okay, well, good evening, everyone. I'd like to thank you for joining tonight's webinar. My name is Gavin Nelson. I'm the chair of the board of Northern Hearts. We're a Thunder Bay-based not-for-profit whose mission it is to promote and educate individuals in healthy lifestyles in an effort to reduce the high incidence rate of cardiovascular disease in Northwestern Ontario. Just a few points for tonight's webinar. We will have an opportunity for some questions, so you can actually enter your question to the panelists in the chat bar, which you will locate at the bottom of the Zoom window. As well, tonight's webinar is being recorded, so we will upload a link on our webpage, www.northernhearts.org, so that you can view the playback. It'll likely be up there tonight, and we'll leave it up there for a while. As well, just sort of tying in with the question and answers, we would ask that you do try and keep your questions somewhat relevant to the topic of the webinar this evening. We would just appreciate it because I'm sure there will be lots of questions. So tonight's webinar, the title is Heart Attacks in Women, Special Considerations. So cardiovascular disease continues to be the leading cause of preventable death in Canadian women. Tonight, we hope that you can become aware of some of the unique risks and symptoms that women face regarding heart attacks and in this webinar. Our host tonight is Dr. Rosie North. We are very fortunate to have her volunteer her time tonight. She's an emergency room doctor at the Thunder Bay Regional Health Sciences Center. She was born in Thunder Bay and is passionate about promoting women's health through prevention and encouraging women to adapt a healthy and active lifestyle. So I'd like to sort of pass it on to Dr. North, and I hope you enjoy tonight's presentation. Thank you very much.
Thanks very much, Gavin, for the lovely introduction. And thanks for the opportunity to speak about this topic. One of the main barriers to women's health when it comes to cardiovascular disease, I think, is an overall lack of awareness in the research. And I think this is a really important topic that you've picked. And tonight, is totally in keeping in lines with the Canadian and American Heart Association guidelines in terms of how do we actually reduce these, the mortality and morbidity rate for women who suffer from heart attacks. I have the Q&A open. I am an emerge physician, so I have not the longest attention span, so feel free to jump in and raise your hand or ask a question. I hope that this presentation can be interactive. I've left, the presentation is probably going to run for about 25 to 30 minutes, and then I've tried to allocate the remainder of the evening for questions. We are going to go through a broad overview as to an explanation of what the literature says, what our best guess as to why women tend to suffer worse outcomes from cardiovascular disease and heart attacks than men, and what the overall recommendations are for going forward, and what the overall recommendations are for you and your loved ones specifically. So in terms of the historical background, I have PowerPoint open up in not in the presenter view. Gavin, can you see just the PowerPoint, or do you also see the chat and the Q&A that I have open?
I can just see the PowerPoint. Are you able to do it in slideshow?
Yeah.
Perfect.
Okay. Okay, so historically speaking, the mortality rate for cardiovascular disease has been greater for women than men since 1984, and the data still persists since then. Overall, since then, there's been dramatic reductions in disease mortality overall, but women still tend to have worse outcomes in terms of they die more and have more, if they survive, they have tend to have worse effect on quality of life. from heart attacks. The major reductions in why we're starting to improve things has been mostly attributable to an increase of awareness of the issues affecting women and the differences in how they present to the emergency department. A much greater focus in the literature on women and cardiovascular disease risk. Historically, most of the studies were involved, the majority of the participants were men, and we started out by generalizing those findings to all genders. But as of more recently, we've really come to understand that there's quite a few subtle differences. So the research going forward, not only have we tried to raise awareness in women, but the studies and the trials on therapies, whether it's medications or surgical, have significantly improved the enrollment of women in those trials. In 2016, the American Heart Association released a really big paper about their scientific statement on heart attacks in women. And they came up with a list of priorities on how to improve outcomes in women with AMI, or acute myocardial infarction, which is another word we use for heart attack. And the number one at the top is increasing awareness of not only women as patients, of healthcare providers, of the public, and of policymakers, of the different symptoms and clinical presentation in women. So totally speaks to tonight, and great job for Northern Hearts for organizing this event. So what actually are the differences? I'm going to break them down in terms of outcome, presentation, and why we think these differences exist. So in terms of outcome, overall, regardless of age, women tend to have a way higher mortality rate than men from heart attacks. Within the first year of a heart attack, more women than men will die, and that's 26% compared to 19%. And within the first 5 years of a heart attack, again, not only will more women die, but more will have heart failure and more will suffer from a stroke. Women tend to have longer hospitalizations and in-hospital mortality. They have way more bleeding complications and are much more likely to be readmitted to hospital from complications after their heart attack. And interestingly, there's very little research on return to sexual function as well for women that suffer from heart attacks. Not that there's a ton of research for men, but the recommendations tend to be way more mainstream in terms of avoiding like nitroglycerin use with Viagra and stuff like that. And there's little recognition, I think, for this area specifically. We tend to forget about counseling women on return to sexual function. There's a lot of issues where they might be like scared to go back to that, and there's a lot of changes that happen to their bodies, and the medications do all kinds of things in terms of affecting libido and even sexual function and vaginal dryness and stuff like that. So why? We think that there's key differences in the biology, which seems to be attributable, what we think is to estrogen. Estrogen we think, has a protective coating of the blood vessels, which tends to reduce blood pressure and reduce overall plaque in the arteries. Hence, when women become postmenopausal, that's when their cardiovascular risk tends to go up. The research on this is kind of mixed, and we don't really have, it's so complicated to try to tease out, but we think overall that estrogen plays a huge role in this. And then further, there's huge gender differences in how this has been studied based on environmental and cultural factors. And this I just briefly touched on. Women tend to, in the past, were far underrepresented in research on heart disease. So to break it down a little bit further, I'd just like to go through what a heart attack actually is and what causes a heart attack, because there's some subtleties in how women actually have heart attacks. So typically, a heart attack results from a blockage in an artery that causes the blockage to stop blood from reaching the heart muscle. And in stopping blood, it stops oxygen as well. And so a part of that heart muscle dies. So in the top part of this picture here, this would be a traditional heart attack where you've got coronary artery disease, which means you've got plaque building up in the artery. The artery eventually either blocks off because a piece of that plaque lifts off and causes a blockage. In terms of the actual plaque breaking off, men tend to have, we think, more of these events of the plaque breaking off and causing a blockage, whereas women tend to have more of an erosion of the plaque, and that's also a little bit hard to tease out. So there's some subtleties in the actual differences in how they have heart attacks on a biological level. And then there's these other more rare events that also cause heart attacks, which are way different from traditional plaque rupture. These two are called coronary artery spasm and a spontaneous coronary artery dissection. So women are, these are still both two rare events, but women tend to have way more of these, of both CAS and SCAD than men. So vasospasm is where instead of you have a blockage from the plaque breaking off and blocking the artery, vasospasm happens when the artery spasms on itself and blocks off blood supply that way. And the dissection is much more complicated. It's where you develop a tiny little tear in the inside lining of the blood vessel. And that eventually rips up, and then causes a blockage. And Kayla's just asked a question: what are the most common age groups for women having heart attacks? So still, women tend to have heart attacks overall. Like, heart disease tends to be a problem with of older people. Commonly, women tend to be in their 70s and up when they have heart attacks. And then the other issue is that women tend to have more episodes of Takotsubo cardiomyopathy. And these can cause heart attacks as well. You guys might be familiar with what's called the broken heart syndrome. This is what this refers to. So women tend to have more events of Takotsubo cardiomyopathy, which also leads to like tissue death of the heart muscle. This is a really complicated phenomenon where we think it's like partly stress induced, which is what the broken heart syndrome refers to. But what happens is the ventricles relax, become really stretched out, and can't effectively pump blood forward. And in pumping blood forward, not only can they have a hard time pumping to the body, but also perfusing the actual heart muscle. And then this can cause a heart attack as well. So in terms of the biological differences, there's some subtle differences in how women actually have traditional plaque rupture. That they tend to have more incidence of the rare causes of heart attacks, like SCAD and CAS and Takotsubo cardiomyopathy. What are the risk factors? They're the same as for men. However, the ones that I have highlighted here, obesity, high blood pressure, diabetes, and stress and depression, tend to disproportionately affect women more than men. Obesity in women, high blood pressure in women, diabetes in women, and stress and depression in women all tend to be correlated with a much higher risk of heart disease than in men. There's no significant difference for high cholesterol and smoking. It's the same across the genders. This is probably my where most of my experience and stories lies, that there can be huge differences in how women present to the emergency department. To speak to Kayla's question, women tend to be older when they present with their first heart attack, with an average age of about 72 years compared with 65 for men. And again, this goes back to the thinking about estrogen playing a protective role before menopause hits. So the years in which women present more with heart attacks tend to be post-menopausal. Women also tend to present with more atypical symptoms, and we'll go through what the atypical symptoms are defined by. And interestingly, young women who are under the age of 45, overall, when they present with a heart attack, they have less presentations that involve chest pain. So it can be more challenging to be diagnosed. We have, I'm sure myself and I think Andy Affleck is in this presentation, or is sitting in as a participant. And Dr. Affleck was a emerge physician who just recently retired, but I've worked with for a long time. And we can definitely have terrible stories of heart attacks that were missed in women just because they presented not with a typical chest pain that was radiating to wherever. Sometimes it's hard to convince, even though the ECG is concerning for a heart attack, when somebody's not exactly complaining of chest pain in front of you, sometimes it's also hard to convince the specialist to act on what the ECG looks like. So we talk about these atypical symptoms, and I just want to define what that actually means. The typical symptoms of a heart attack classically is chest pain. There's features about the chest pain, like the fact that it radiates to one arm, both arms, the chest pain being associated with shortness of breath, with vomiting, with sweating, the chest pain being related to exertion. So chest pain that started after walking up a flight of stairs. These all describe the typical chest pain symptoms that are related to a heart attack. Unfortunately, the challenging thing in terms of diagnosing a heart attack is that women tend to present more with what we call the atypical symptoms. So instead of their chest pain being pressure, tightness, squeezing, they tend to describe it differently. It was this kind of weird aching, my chest just feels sore. It hurts when I put my arms up or when I lift something. Versus the classic, I got chest pain going up a flight of stairs today. And then not only does their chest pain tend to be a little bit different, but they also have some other symptoms that go along with their heart attack that wouldn't necessarily be classic looking at the textbook. So they often describe like fatigue, or I'm just not feeling well. I think I got a touch of the flu. I feel a little bit dizzy. I just don't feel good. I'm feeling a little bit weak. I think this might be indigestion. or the pain is in my shoulder, jaw, and back, but nowhere near the chest. Unfortunately, when somebody presents with the atypical symptoms or the less classic symptoms, it's just more challenging to diagnose. But I think with raised awareness, in terms of not only just patients, but also providers, this is helping us pick up and I think do a better job of listening to these symptoms. So what's the consequence of missing the heart attack? Obviously, like death, maybe not that day with that initial presentation of heart attack, or sorry, with chest pain that might be atypical, but if undiagnosed and undetected heart disease might lead to death within 30 days or 60 days. And then if that patient doesn't die from a heart attack, alternatively, they end up with the scarring, which leads to the remodeling of the heart and unfortunately heart failure down the road. So why do we have these delays in care and why do we miss heart attacks? The lack of awareness was one thing that I pointed out a couple times today in terms of both patients and providers. Interestingly, women who have already had a heart attack or have a history of diabetes, hypertension, and heart failure or cholesterol problems also don't tend to seek care as much. I think they probably just attribute their symptoms as, to maybe their chronic disease. And a huge risk factor, I think, tends to revolve around the social issues. Women that live alone or tend not to, and I'm not sure why, but they tend not to present as much for symptoms that they're concerned about. I think they probably are interpreting their symptoms as non-urgent, or maybe they just don't want to bug somebody, or they're embarrassed about seeking care. So at the end of the day, I think it comes down to not only raising awareness, but reducing risk factors. So having known these big biological differences and the differences in presentations in terms of how what a heart attack might sound like in a male versus a female, we do need to continue to spread awareness about these differences. And I think at the end of the day, it's about risk factor reduction as well. And the research here is not new at all. The risk factor reduction advice has been the same for a long time. It's about healthy, active living, not smoking, eating a heart-healthy diet, and managing overall stress. That was the brief summary of my deep dive into the research. And now I would actually like to open it up for questions. I'm, I guess, just about on time.
Thank you, Dr. North. I will give everybody a chance just to formulate some of their questions. Maybe just to kick it off, I guess, what sort of role is it, like genetics, hereditary? My understanding, at least, is that if you have a history of heart disease, that you could potentially be at risk yourself. Is it the same for women as it would be for men, or in general?
Yes, the genetic risk factors associated with heart attacks, that one tends to be the same across the genders. And that speaks to the family history of coronary artery disease. So if your first degree relatives had a heart attack, which is like mom, dad, or siblings, you're at increased risk. If you yourself already have known heart disease, then we're looking at what's called secondary prevention. So you will always be at increased risk of having a heart attack.
Great, well, that answered that. I guess as a follow-up, well, it's not really related to the first question, but as an ER doctor, I'm sure you have a lot of anecdotes that you can share from scenarios that you've sort of talked about tonight. Is there one in particular where you can sort of say, well, there was a person that came in that had no idea that they were, having a heart attack, and that you sort of an atypical symptom that led you to sort of pursue tests for a female or for a woman?
I've been in practice for just a few years. I have two, I think, terrible cases. As of more recently, we had a young woman in her 40s who recently came in with what she described as like initially vague chest pain, but then was more shortness of breath. And her EKG showed an obvious heart attack within minutes of her rolling through the door. But she wasn't actually complaining of chest pain when we had the ECG done. But the like, you can't ignore an ECG that is that obvious. So we talked to the what we call the PCI, or the angiogram team that's on call, and they agreed to take her up. She did not have traditional plaque rupture. She ended up having a spontaneous coronary artery dissection, which explains why she didn't necessarily have chest pain at the time. She probably had chest pain when it dissected off and then settled. And the damage was being done, but her symptoms were related to the fact that this wasn't a classic plaque rupture. So she obviously needed like immediate care and stuff. So it's good that they took her up to the angiogram. We just finished an M&M's case, which we do monthly in our emerge department, of a woman who wasn't necessarily complaining of chest pain at the moment when her ECG looked like she was having a heart attack. So there was a delay in actually taking her up to the angiogram suite. She had some other issues going on, and I think they were mostly psychosocial related. She had to go home to look after a kid that she'd left alone as a mom. She ended up coming back 8 hours later, fully aware of the risk benefit of leaving. Unfortunately, her EKG and her cardiac enzymes were much worse when she came back. And she unfortunately went on to damage or to develop the sequelae, which is some remodeling. And in her 40s now, she's at much higher increased risk of heart failure and another heart attack. And I see some questions coming in the Q&A. So I will just, I guess, take them one at a time. Diane asks, is there any connection to heart disease and other conditions such as CF or Crohn's or colitis? Most definitely. So the sex differences here aren't particularly well documented, but in the last, I'd say probably, and Dr. Lai can correct me, but I'd say in the last like 8 years, there's been a much better recognition of how inflammatory conditions increase your risk of heart disease. And these conditions include all things autoimmune. So lupus, rheumatoid arthritis, inflammatory bowel disease, all those families of autoimmune illness increase your actual inflammation at the cellular level. And the increased inflammation is thought to contribute to your increased risk of heart disease and heart attacks. So I see Sharon raising her hand, and then I'll go back to the Q&A. Sharon, I'm going to click allow to talk. Let's see if that works.
I'm just wondering what foods you would recommend to avoid. I mean, you know, fruits and vegetables are important and stuff, but are there types of foods or certain foods to avoid to prevent heart disease?
Yeah, and Sharon, I just got distracted by the chat. You said you're asking about foods to avoid. That's right.
Yes.
Okay. The overall, it's things that have high saturated fats and cholesterol, and things that are processed and have a high sugar content, which the sugar stuff increases your risk of diabetes and obesity. The actual high cholesterol, high saturated fats can contribute to the development of cholesterol in the arteries. So there's quite a few diets that have been recommended from a heart healthy perspective. They traditionally was like the non-saturated fats, no added salt, but they've been expanded more broadly to include things like the GI diet, the Mediterranean diet. I think overall the big arching message is that everything is good in moderation. Try to reduce your intake of saturated fats and things that contain a lot of cholesterol. So that's like butter and red meats and stuff like that, and reducing the processed and like sugary foods.
Thanks.
Okay, I'm popping back to the Q&A. Anonymous attendee asks, does an arrhythmia like AVNRT that arose in menopause cause an increased risk for heart attack? So not necessarily. AVNRT is an electrical problem with the heart, which is different from the buildup of cholesterol in the arteries. So if you think of like, sometimes I break it down into like cholesterol buildup being like a plumbing problem, AVNRT is an electrical problem. And they don't necessarily have a big overlap. I think there's other risk factors that have that play a way bigger role for increased risk of heart attack. And I've got Linda Adams. My husband has had part of his ascending aorta replaced 15 years ago. He has creases in his ears. I was told that this is a sign of heart disease. Does this happen in women too? I actually don't know the answer to that. Linda, does he have, I can find you in the participants. Linda, does he have a valve problem that's related to connective tissue disease?
Well, he's had his valve replaced. He has a pig valve.
Okay. I'm not, and he's got creases in it. So your question's about the
Yes.
women. Yeah, I don't know.
And
The
they're quite pronounced.
Is this because he has a connective tissue disorder?
I don't know. I was just curious because they're quite pronounced. And I think it was, I'm not sure if it was here, if it was in Toronto. I asked somebody about it. And it was a nurse that I asked, and she said, oh, that's because of the heart disease. And I was just curious about it.
Yeah, I don't know. I'm not sure. If you've got connective tissue disease, which you can sometimes see in like other connective tissues areas like ears, then that increases the risk of valve disease, but not necessarily heart disease.
Thank you.
Okay, and oh, Dr. Lai. Dr. Lai has his hand up. I'm gonna let him talk. 1 sec. There.
Could you hear me?
Yeah, we can hear you.
That young lady is a question about the so-called oral sign, and the oral sign is first discovered by a medical student in Toronto. And yes, the answer to that question, yes, is highly associated with coronary disease. So whoever heard the story is quite correct. Thank you.
Thanks, Dr. Lai. So that's like genetic related problem?
I'm not too sure it's genetic or not, but certainly is associations, is a markers for developing of coronary artery disease.
Perfect. I'm gonna keep you your bubble here in case we bug you for other questions. I've got Petra. When going for an annual physical, what tests would be asking our family docs to request specific blood work, EKG, stress tests, anything else? Can you relate this to the patient's age, hypertension, diabetes, or family history? I think the best tests are screening for diabetes and checking your blood pressure in the office and monitoring for high cholesterol. The stress test in somebody who's asymptomatic, or a baseline ECG for somebody who doesn't have who's not actually having a heart attack or not having symptoms, actually aren't helpful when they're ordered in the family doctor's office for an annual test, like the physical. The stress tests are helpful really only in selected people who have symptoms that aren't clear, but no longer as part of your annual health checks. I think that probably the most important tests are screening for diabetes, checking your cholesterol, and having them measure your blood pressure in the office. And that's even would be the same for somebody who's got risk factors like high blood pressure and diabetes and a family history. I'm just going to pop back to the other chat questions and then go back to the Q&A. So Barb asks, how can you reduce plaque in the arteries? Okay, so in terms of reducing plaque, there are modifiable risk factors and non-modifiable risk factors. The modifiable ones are all based on lifestyle factors and what we can control. So you can reduce plaque by not smoking, by lowering your cholesterol, by maintaining a normal blood pressure, by reducing stress, by avoiding diabetes or controlling diabetes, all the typical risk factor reductions. I think the biggest one is probably in terms of reducing cholesterol and blood pressure, it comes down to diet, exercise, stress management, and not smoking. Same thing every time. That hasn't changed for like a really long time. Darlene asks, is there a role for supplemental estrogen for postmenopausal women? Okay, so interestingly, this has been studied a little bit. There's some risk that is associated with estrogen as well from a clot perspective. There hasn't been shown to be a reduction in heart disease for women who are postmenopausal, even if you supplement them with estrogen, but it's has been studied just a bit. Dr. Lai, do you have anything else to add here?
Yeah, it's interesting you said that because of the fact that we do know that inside the lining of the blood vessels in the whole body, that we call it estrogen receptor site. Certainly, the estrogen receptor site are protective of building up plaques. So there is a certain study to show that why the premenopausal women had less incidence of coronary disease because of estrogen floating around and protecting and attaching to the estrogen receptor site in the blood vessel, that's including the blood vessel inside your heart. So certainly when you are postmenopausal, you take estrogen. Unfortunately, you also have to take progesterone to release the building up in the lining of your uterus. So that is a problem that we're facing when you take the progesterone. There are several studies that show that if you use a different form of estrogen, so-called micro dosing, it may be protective, and you don't need the progesterone to release the thickness of the uterus, and therefore less likely to develop cancer in that area or endometriosis. So certainly it's still controversial at times, and whether we should or we shouldn't be giving people postmenopausal, giving them estrogen supplement, but certainly you can talk to the gynecologist and they could guide you through what type of estrogen should be best for you.
Thank you. Rosemarie asks, or I think she just comments, being alone, I think that I put off going to Emerge simply because I don't want to face it by myself. Okay. I really want to thank you for commenting on that and adding your opinion. We in the emergency department, I think if I could give everybody one big take home from this presentation tonight, we are so happy to see you for anything that you think might be heart attack related or not, or if you're not sure, if you think you're having the flu, or if you're not sure if these are atypical symptoms, or maybe you're actually having the big one. I see a lot of people with chest pain that I sent home at the end of the day. That's nothing, like it was not a heart attack, and nothing to worry about. And I'm very, very happy to see you and reassure you and run the usual tests, and send you home and let you know that it's okay. Whatever symptoms you're having were not cardiac related, but by all means come in. I know right now with COVID, it's hard to come in even more because of our visitor restrictions, which are really hard and can be really frustrating. But please, if you think you're having a heart attack or you're not sure, please come in. We are happy to see you. And then a couple more in the chat. Marjorie says, I've had 2 heart attacks, and both times I had pressure in the right upper chest and up into my neck, diaphoretic, shortness of breath, and feeling of weakness. More severe with the first one at 55 years old. So that's a perfect example, unfortunately, Marjorie, of maybe that wasn't necessarily you had some typical features and some atypical features, but definitely speaks to the point about how women who've already had a heart attack once, if they have a subsequent one, their symptoms, they tend to not be the same, and so they're at risk of dismissing them or delaying coming in. And Vicky says, can you touch on hormonal birth control use and heart disease risk factors? Is it long-term or just while the medication is being used, i.e. in use in your 30s, a risk factor when you're over 60? I don't think hormonal birth control use when you're younger has been significantly associated with risk of heart attack. That kind of clotting is more associated with risk of different kinds of clots, like blood clots in the lungs or in the brain, as opposed to actual heart disease. I think, Vicky, can I ask you a question on that? Can I let you jump in if I find you in the Vicky, were you referring to like just birth control, or do you mean other hormone types like birth control or things like estrogen?
Well, like things like estrogen are more for like menopausal women. I was just thinking more just, I know there's an increased risk of stroke. I just wasn't sure if there's any sort of like, yeah, arteriosclerotic diseases and stuff that are associated with the hormonal birth control. Like any hardening of the vessels, anything like that.
No, there doesn't
Not
seem to be
particularly.
a huge increased risk.
Okay.
I think if there was, it'd be really hard to tease out just because it's so multifactorial. I'm gonna let Dr. Affleck jump in, but not to my knowledge.
Hi, Rose, thanks. Actually, I want to jump back to something you said, and as far as I know, there isn't any risk with the birth control pill at a younger age until you're menopausal. So just going back to one statement that I think you said is a good take home, and I think probably one of the most important ones is people never bother us in Emerge. I've worked in Emerge for 35 years. I've never had anybody come in and bother me in the Emerge. What I have seen is many people coming in thinking they were going to bother us come in late. Then you end up with complications, more disease, you end up damaging your heart more. And I think more and more as we learn more and more about heart disease, we know it's very important to come in early. So aside from heart disease, it doesn't matter. If you think you have something that needs to be looked at, I think it's very important to come into the emergency department to be looked at. I've never seen one of my physicians really comment that somebody with chest pain came in and didn't need to come in. It's one of the things in Emerge we always consider is we always consider the worst scenario and try to rule that out. And hence, nobody who comes in should feel like they're bothering us. That's what we're there for. And the other thing I'd mention is in COVID, I've seen it even more. I've done a lot of virtual emerges, and I've had 2 people come on the virtual emerge with very typical chest pain of cardiac disease that ended up having cardiac disease where they should have gone to the emerge. So once again, just to emphasize, if you do think something's going on and now you've learned about the atypical presentation, I think it's very important to go in and be looked at.
Thanks, Dr. Affleck. Popping back over to the Q&A, AMV asks, I'm in a COVID study and I have heart disease related to COVID inflammation. Have you seen others with this? I've seen a couple post-COVID syndromes and complications of COVID. Definitely the biggest one, the biggest symptom I tend to see as a complication of COVID is fatigue and persistent shortness of breath. Maybe, and at Thunder Bay, like our COVID numbers were bad for a while, but I haven't seen a ton of this. I don't think I've seen any heart disease specifically related to COVID inflammation, but that's really unfortunate. Maria asks, do genetic blood clotting disorders increase odds of AMI or acute myocardial infarction? The genetic blood clotting disorders increase your risk of clots in other parts of the body. This is like similar to what birth control increases your risk of. More so clots in the legs, in the lungs, in weird places like the GI tract, and not necessarily in the heart. The difference being that blood clotting disorders tend to cause clots in the veins. So the circulation in the lungs, the veins in the legs, the veins of the GI tract. Whereas the vessels that we're talking about in heart disease are arteries. So here we're talking about arterial blockages. So arteries are the highways or the blood vessels that pump blood and oxygen to the heart, the brain, the kidneys, arms and legs. Veins being the ones that return deoxygenated blood back to the lungs to get oxygenated. So blood clotting or genetic blood clotting disorders tend to cause problems in the veins as opposed to the arteries. Okay, and Holly asks, is there a correlation between acid reflux and heart disease or heartburn? Sometimes that feels like chest pain And when should someone go to the ER? So great question. I think if you're not sure if this is your heartburn or if this is a heart attack, just don't hesitate, just go to the emerge. I think the correlation is probably there's people that think they might be having reflux symptoms that are actually having like anginal type chest pain. And Pat asks a similar question, heartburn after eating, could this be a sign of heart disease? Having reflux, and I'm not sure if I hope I'm answering your question correctly. Reflux doesn't necessarily, or heartburn doesn't necessarily increase your risk of heart attacks. The question is the chest pain coming from reflux, or is this cardiac chest pain? So that it's hard to say, Pat. I'd say if you're worried, I would head to your local emergency department. Anonymous attendee asks, is magnesium supplementation helpful in reducing the risk of arterial spasm of heart attack? I'd answer that there's not a lot of research here in terms of preventing risk of coronary artery spasm. I don't think magnesium supplementation plays a major role here, unfortunately. Vicky asks, how important is it to get checked for heart issues if you have diabetes and a family history of heart attacks? So Vicky, it's super important. As I'd say somebody who's already got some risk factors, if you develop symptoms, whether typical or atypical, that have already coming to the table with diabetes and a family history, you're at increased risk of having a heart attack. I think your question is asking about screening. So assuming that you're somebody who hasn't had a heart attack, you just know that you've got risk factors around being diabetic and having a family history. Your ways of, or like your recommendations would be reducing your risk factors. So keeping close tabs on your blood sugars, reducing the major risk factors like no smoking, healthy active lifestyle, and heart healthy diet. There is no role for like a screening ECG or a screening stress test just because you've got risk factors. Anonymous asks, can radiated pain upon exertion go to the bicep without being felt in the definitely can. Yeah, chest pain that radiates can radiate to all kinds of like weird places, and this is because the heart doesn't actually have nerve supply that that says, hey, I'm having a heart attack, and I'm having, so that the neighboring structures tends to be the ones that actually feel pain. Pat Seed asks, what role, if any, do heart murmurs and palpitations or fluttering play in heart disease and heart attacks? So murmurs not necessarily have been identified as a increased risk of heart attacks and heart disease. It depends on what the murmur represents. So a murmur can be anything from something benign to a massive valve problem. Valve problems can cause heart failure or aortic dissections, which are different from heart attacks, although can complicate the picture or rarely can cause a heart attack in themselves. But murmurs in itself, without like a murmur that doesn't actually represent a valve problem, doesn't play a role. Palpitations and fluttering have been identified as one of the atypical symptoms that women can present with heart attacks and heart disease. And then lastly, in the Q&A, Diane asks, what about an increase or a new awareness of snoring for women that did not happen before? Is there a concern that can cause heart issues. So if the snoring it represents obstructive sleep apnea, is a significant risk factor for heart disease. That being said, the treatment for obstructive heart disease is CPAP machine and weight reduction. Weight reduction actually reduces cardiovascular risk. CPAP, it's been controversial as to whether or not it actually reduces cardiovascular risk. So thanks, Diana. And then, so it's 7:57. I'm just going to head back to the chat, starting with Mary. Does hypothyroidism contribute to heart disease or heart attacks? The thyroid disease can increase your risk of heart attacks, especially if the thyroid disease was related to an inflammatory condition like Hashimoto's or an autoimmune problem. Hypothyroidism, if it's untreated and leads to things like obesity, it definitely increases the risk of heart disease. And I just have two more, so I think I have time to finish off. Barbara is asking, my x-ray shows hyperinflation. I'm on letrozole and won't have the estrogen now to keep my heart healthy. Will I have heart failure now? Barb, that is a complicated question. Hyperinflation is lung related and tends to be from obstructive lung disease like asthma and COPD. Not necessarily related to heart disease, but there is an overlap of respiratory illness with heart disease, mostly because of the smoking piece. I don't think I can answer that question in terms of whether or not you'll have heart failure. I would save that question for your family doctor or your community cardiologist. It's much more complicated than just estrogen in terms of the development of heart failure. And hyperinflation doesn't necessarily have anything to do with heart failure. And then lastly, Marjorie asks, my dad died at 63. He complained of indigestion and ended up throwing a clot and died. When I was nursing, I had a man who had been in a car accident, broken leg and neck. After sitting him up complaining of indigestion, which I immediately reported, he was rushed over to the ICU with a blood clot. So unfortunate story about your dad, but sounds like you recognize the symptom of indigestion being in cardiac, not actually GI related. So good on you. Okay, so that, I'm just gonna double check the hands that are up. Okay, so that covers the Q&A questions that were formally asked. Thanks very much. I don't see any more at the moment, but thanks everybody for participating and showing up tonight. I think this is a really important event that I think Northern Hearts just does such a great job of raising awareness about risk factor reduction and heart disease in Northern Ontario. It's a pleasure to present tonight, and please don't hesitate to visit me if you're worried about a heart attack or anything else in the emerge.
Dr. Affleck, did you want to jump in once more, or is your hand?
Yeah, I'd just like to thank Dr. North for doing this. I actually asked her to come on and do this, and it's a very great presentation and very enlightening for everybody, and hopefully everybody enjoyed it. The one thing I would just say too is this has really highlighted the atypical presentations that females can have. Having said that, they still can get the typical type of presentations. And if anybody gets the typical type of presentations or have heard this and really have the atypical and you're really concerned, the best thing to do is call 911, especially with the typical presentations. The retrosternal chest pain, going down your arm, sweating, that type of pain, and take an aspirin if you have it at home. because the ambulances have defibrillators that are needed, because the biggest risk up front when you're having a heart attack is for your heart to stop or go into what's called atrial fibrillation. And for that, you need a defibrillator. Over the years, I've seen too many people roll up to the ramp and emerge, having left home with chest pain, thinking they'll get there faster, and arrested in the car on the way into the emergency department. So I just say, if you do have the typical symptoms, call 911 and take an aspirin. Paramedics will take great care of you. They're trained to do this, and they're also trained now to recognize heart attacks so that you can get bypassed through the emerge straight to the cath lab and get direct treatment. So don't forget about paramedics, but also be aware of the atypical presentations that can happen. And Rosie, thanks again for doing that. That was great.
Dr. North, I'd like to also add my thanks on behalf of Northern Hearts. It's been a pleasure working with you and getting this presentation. And I can't thank you enough for the advice you've shared and your insights, and certainly I wish you the very best and continue to look after all those patients coming into ER. We certainly appreciate everything you're doing. Thank you.
My pleasure. Thanks, Brian. I really support Northern Hearts in your initiatives. And I think you guys do a great job for our community.
Thank you.
Okay, so I think that wraps it up for tonight. I think Brian and Dr. Affleck have sort of reflected how fortunate we were that Dr. North came on tonight. And thank you to Dr. Lai and Dr. Affleck for contributing as well. Again, this presentation will be up on the website, www.northernhearts.org, and please, visit the website, and we will be hosting more talks down the line. And again, this one just raised the bar for how great these really are. So thank you everyone for coming out tonight. Thank you, Dr. North, again. Good night.